Dissociative identity disorder is marked by more than one individual personalities in a single patient who is unable to recall important personal information among these personalities. Diagnostic criteria for dissociative identity disorder, as stated by the Diagnostic and Statistical Manual of Mental Disorders, lists the presence of two or more distinct identities or personality states, each with its own relatively enduring pattern of perceiving, relating to, and thinking about the environment and the self. At least two of these identities or personality states recurrently take control of the person's behavior. The inability to recall important personal information that is too extensive to be explained by ordinary forgetfulness. And the disturbance is not due to the direct physiological effects of a substance, such as alcohol abuse or drug abuse, or a general medical condition, such as seizures.
People with dissociative identity disorder have a primary identity that goes along with their birth name. This primary identity may normally be dependent, passive, stressed out, depressed, and possibly plagued with a feeling of guilt. The alters, however, are strikingly different. These alters could possibly act in ways that are demanding on the host, and they may differ in IQ, race, age, gender, behaviors, or even species.
Richard Clough described key features of those with dissociative identity disorder. He describes the classic host personality, who's one that goes out and seeks professional help, as generally being depressed, anxious, compulsively good, and moralistic. And the alters normally represent the hidden desires within the host, as well as children, protectors, helpers, etc. The change of personalities that occurs in someone with DID can be instantaneous. It can be marked by a cough, a sneeze, a change in posture, a blink. It can really be anything. Any small movement, or perhaps no movement at all, could trigger a personality change. People with dissociative identity disorder suffer from different forms of amnesia. This amnesia can span from a night, a few hours, a week, a month or so, or a couple of years. Well, wait just a second. That sounds a lot like multiple personality disorder. Well, that's because it is. The DSM-2 first coined the term multiple personality disorder, and the DSM-3 brought this disorder into the other grouping of dissociative disorders. However, the text revision of the DSM-4 finally changed the term to dissociative identity disorder. The reason for this change was because the term dissociative identity disorder sounds a lot more like the disorder. It implies that you have a host personality and then several branching personalities. However, multiple personality disorder, in contrast, might give the hint that you have multiple personalities and no center personality. Also, people started getting a little bit too cozy with the term multiple personality disorder, and there were tons and tons of people coming out with, "Oh, I have tons of personalities, I have the disorder, help me." So by changing the term to something that people don't normally understand unless they research the disorder, kind of helped lower the prevalence rate. Just kidding, kind of. Dude, you'll never guess what just happened to me, man. Like, I just got diagnosed with multiple personality disorder, and, like, this stuff is serious business. And me and my brother Richard, and when I mean brother, we talk all the time, dude. This is, like, serious. Are you even listening to me? I have a disorder. Serious. Dissociative identity disorder is thought to be caused by abuse during adolescency. Richard Clough, who did what? Richard Clough described key features of those with dissociative identity disorder. Believes that treating dissociative identity disorder is similar to treating those with post-traumatic stress. The sociocognitive model of dissociative identity disorder explains that it's not quite certain that someone might have been abused when they were a child, more so as they are developing these personalities as they believe is expected of them by society. Yes, it does give room for having been abused or traumatized as a child. However, it also explains that there could be different reasons for this as well. The most common treatment of dissociative identity disorder is hypnotherapy. The clinician might ask that the alters speak out on their different memories. Due to the stressful nature this has on the host personality, as well as the differing attitudes of the alters, this therapy can be incredibly trivial, time-consuming, and difficult for both the client and the clinician. In addition to talking about the pros of using hypnotherapy, our textbook also mentions that the use of hypnotherapy can cause more harm than good in a patient. The textbook explains that it might do just the opposite of what is intended on the patient. That's right, it could potentially create more personalities and make the problem worse. Another treatment option for those with DID is the cognitive behavioral approach, which instead of using hypnotherapy, or perhaps with the use of hypnotherapy, the clinician tries to hone in on the feelings of the host personality, which are feelings of inadequacy, stress, dependency. By honing in on these character traits and trying to alleviate some of the stress from the patient and raise her self-esteem, this may perhaps help alleviate some of the symptoms of dissociative identity disorder. The alters are hypothesized to have been created due to a feeling of inadequacy or a feeling of conformity to society standards. By raising the patient's self-efficacy, this may be a very viable treatment option. Dissociative identity disorder is a very controversial diagnosis that can range from the case of Sybil and Eve to something that can be much more mild. Imagine the weight on both the host personality, the patient, and the psychologist as they try to treat this disorder. It can take years to try to treat and integrate all of these different alters. It's very controversial for a clinician to try to integrate the different alters inside of the patient's mind, because the different alters have different memories, but the host has no recollection of these memories whatsoever, with the alters trying to explain their own memories if they wish to do so, and the therapist trying to help the patient piece together all of these memories to fill the large gaps of amnesia. The clinician might accidentally integrate false memories into the patient's mind, which also can do more harm than good. Dissociative identity disorder is still a sensitive subject in the world of psychology, and any reliable data will be crucial to the further understanding of this disorder. Thank you.